When we talk about public health and health, particularly for moms, access is something that we talk about frequently. Access is not just being able to reach the services that you need, but reach them in a culturally aware way. The mobile bus does exactly that.
We have our mama and baby mobile unit. It has 2 clinic rooms where our team of midwives works with folks to provide them prenatal care, STI counseling, really anything that you can think of as a women's health service. And really the goal is to improve access to quality maternity care for women who are living in maternity care deserts or places where they can't otherwise receive good access to care.
Mobile units like this one is excellent in terms of getting care to individuals who are marginalized.
So these moms are really, really thankful to be able to find a place that first of all is going to take care of all their pregnancy needs. And we're talking about they're going to get an ultrasound on this bus, they're going to get their lab work, they're going to get full scope OB care on this bus, and it's going to be free of charge for them.
It's really important to bring together the multi-sector partners and bring community and build community around those pressing social issues and focus areas. And we know that maternal infant health is one of those.
Not only are there providers and community that are looking to help moms thrive, but we're actually putting our money where our mouth is and showing those investments, investing in things like the mom and baby bus and bringing them to them. That next level of care, being able to be competent and being able to provide services that we know are critical to change the infant and maternal mortality rates in our city, for moms to be able to access that is just amazing.
Thank you for joining our panel today. My name is Shireen Simon, and I will be our moderator for this panel on shifting maternal health outcomes through access and quality care. So I would like to invite our panelists here to introduce themselves and then a little bit about their work and the organization that they work for, et cetera. So we'll start down there.
Good morning, everyone. My name is Erica Richards. I'm the chair and medical director for the Department of Psychiatry at Sibley Memorial Hospital. I've been there for, my Sibley crew is here, everyone. So I'm an assistant professor at Johns Hopkins, and part of my interests and additional training are in postpartum and peripartum mood disorders. So I look forward to talking more about that today.
Good morning, everyone. I'm Dr. Yolanda Hancock. My most important job is that of mother. I'm the proud mommy of Amara, a rising 5th grader. When I'm not doing that, which is never, I'm always doing that, I'm a pediatrician. I'm here representing the American Heart Association as a member of their executive board for the American Heart Association Greater Washington region. And I'm extremely excited to be here to be part of this conversation.
Great. Good morning, everyone. My name is Dr. Dorothy Fink, and it's been amazing to meet the incredible people on this panel and to represent the Department of Health and Human Services Offices of Women's Health, where I direct the Office on Women's Health, and I also have a little 1-year-old at home, and so these issues are something that we are all really passionate about and can't wait to share more.
Good morning, everyone. I am Robin Diggs Perdue, Deputy Director for Policy Programs and Strategy at DC Health. And I'm very happy to join these panelists here today and talk to you a little bit about what we're trying to do to address the health disparities that we finally need to tackle here in the district. I've been with the Department of Health for about 20 years. And started in public health when I was around 15 years old, and have always been committed to eliminating the racial disparities in health in this country, and I'm very happy for the opportunity to be with DC Health and to work here in the District of Columbia.
Good morning, everybody. I'm Joanne Armstrong. I'm an obstetrician, gynecologist. I'm Vice President and Chief Medical Officer for Women's Health at CVS and Aetna. I'm also an associate professor of OB/GYN at the University of Texas in Houston, the mother of 2 children, the first one with severe maternal morbidity, and so speak about these topics from personal experience and also at a public health level.
Thank you so much, panelists, for joining us today. And my name is Shireen Simon. I am the Senior Director of Health Equity at the March of Dimes, and I'll just be kicking off our talk. So we all know that in an ideal world, it is absolutely possible for birthing people and mothers and infants to have positive health outcomes. We know that it's possible. However, our current reality does not meet that, and that there are a lot of challenges and issues. So I'd like to actually open it up to everyone to ask you, what are the common misconceptions that people have regarding maternal health? And what do you actually think are some of the things we can do to combat those misconceptions and to communicate more effectively to have more positive outcomes?
I'm always excited to start with a discussion about mental health. So I want to highlight a few things from my perspective that are misconceptions prior to pregnancy. And one of them is that I can't be on medications for my mental health and have a healthy pregnancy and not do any damage to baby. And I want people to understand that that is not true. One of the things we want you to do is really take care of your mental health, even sometimes before you start planning for families, because what we know is that untreated anxiety, untreated depression, untreated mood disorders are actually related to poor outcomes for baby. And so one of the misconceptions that I want everyone to realize is that you can be on, if necessary, you can be on medications and still have a healthy baby. And number two is that it really is important to see somebody to talk about these things if you're feeling that you might benefit from additional mental health treatment. There's not a reason to wait. The third is that baby blues is truly very frequent among people after they have a baby. And so we want you to understand that you might have these dips in your emotions. You might feel kind of like you're not enough. You might feel like your family doesn't need you. But we really still want you to talk about that. Most people will see their OBGYN shortly after delivery. We want you to talk it over with them to see, is this kind of on that normal spectrum, or would I benefit from additional treatment because my emotions are even stronger than that?
And when we talk about misconceptions outside of mental health, but with regards to perhaps the pregnancy journey or the postpartum journey, what are some other misconceptions that are brought up?
I would say the misconception is that improving maternal outcomes starts and stops at the individual level. We have to truly address the social determinants of maternal outcomes. I think back on my foremothers and what my great-great-grandmother experienced, the fact that my ancestors delivered babies and had to serve masters within a day or two of delivering. That culture in this country did not disappear. It's perpetuated in the workforce now. I did all the right things when I was pregnant. I ate the right foods. I followed the American Heart Association recommendations of eating less than 25 grams of sugar per day. I taught Zumba for 6 months of my pregnancy, and I still almost died the day after I had my daughter because of a hypertensive crisis. And so when we talk about improving maternal health outcomes, we have to talk about each of us affecting change in the workplace, politically, in our housing environment, all of those factors where a woman, even before she thinks about becoming pregnant, when the eggs that developed her are in the womb of the woman who's in the womb of the woman who's experiencing stress from slavery, Jim Crow, all the way through now. How does all of that societal stress impact our, particularly Black women's, ability to have a healthy pregnancy?
And in addition to maternal stress, so I'll ask this to Dr. Armstrong, what are some predisposing factors for maternal morbidity? And when we say morbidity, we mean illness and sickness during pregnancy.
Right, so morbidity is a sort of fancy medical word for just problems that happen during pregnancy or during delivery. So when we think about them, they are things that happen. They can be short-term or they can go on for a very long time. In fact, they can affect your entire life course. Some of the common morbidities that we talk about in pregnancy are things like diabetes, hypertension, heart disease, lung disease, infection that often results from complications of a cesarean delivery or an induction of labor, bleeding that often is also a consequence of the delivery, cesarean section, or problems with the placenta. And then importantly, an important morbidity is depression and anxiety that is related, can be related to the delivery. So those are the morbidities that we think about. to address like how to affect those morbidities, we link them back to what are the underlying risk factors that gave rise to them. So those things are pre-existing medical conditions, what we come into delivery with, and how they affect the delivery and beyond that time, our past obstetrical history, things that happen in prior pregnancies like preeclampsia or placental problems, they carry with us. Our age, being older, we can't change that, but we can closely follow pregnancies because of that. So there's a whole range of medical risk factors, the number of babies that we're carrying, twins and triplets. But then we talked, this morning's panel was just fantastic about all these other risk factors that affect our morbidity that are related to racism, racial prejudice, ethnic prejudices, and then this system, this really dysfunctional economic environmental system that we live in that drives us to our access to food, our access to safe neighborhoods, our access to places to exercise, and then importantly, our access to the healthcare system. We heard about, Case Western or other beautiful healthcare systems, but people that live right around it can't access it. And some of it is because economically they don't have access to it, but some of it is health systems are sort of set up for 5-day-a-week enterprises. But we don't live that way. Like, I think our 5 days a week, I'm doing something else. It's not my doctor. So we really need to think about other ways that real people access healthcare and need access to healthcare, and all the other people in that ecosystem that do that. Nurses, pharmacists, right? There are hundreds of thousands of pharmacists in the country. There are 10 states now that allow pharmacists to actually prescribe medications, PEP and PrEP, contraception. These are points of entry into the healthcare system that, regular people, not sort of an academic studies, but regular people living their lives need this. And we really need to expand that for all sorts of telemedicine and all sorts of providers. So anyway, those are the morbidities. It's a roundabout answer. And then once we understand the risk factors, then the question is, where are points in pregnancy that we can really intervene? And I just want to make a really strong point for the preconception period, because we forget about that. Half of the pregnancies in the country are not planned or mistimed. And that's really a big opportunity to address prevention that can mitigate some of these risks, whether it's through vaccinations, cervical cancer screening, optimization of these medical factors that once you become pregnant, really accelerate either their medical course or the impact on pregnancy. So we have to do better about meeting people where they really live in the communities and the life that they have.
And I want to just hone in a little bit more on one of the comorbidities. And so similar to you, Dr. Hancock, I did all the right things during pregnancy too, and I still got preeclampsia, right? So from your perspective, we know that pregnancy is like a stress test for the heart. So if you can share a little bit about the importance of heart health during pregnancy, perhaps before and also after.
It's an excellent question, and one that the American Heart Association has dedicated extensive resources to. It's important to understand, really, just in terms of physiology, the changes that the body goes through when you are pregnant. Your blood volume increases by up to 30 to 50% in order to nourish this growing fetus, and with that, it increases how hard your heart has to work in terms of the amount of blood it pumps, the rate that it pumps, and then the relaxation of the blood vessels, so the blood can make it to all of those important parts of the body. When you come into a pregnancy without optimal pre-pregnancy health, specifically from a cardiovascular standpoint, it increases the risk of developing complications, both for the mother and for the baby. And as it stands right now, cardiovascular disease is the leading cause of poor maternal outcomes, particularly for African American women. For Black women, we have more than double risk of going into a pregnancy with challenges in terms of our cardiovascular health. The peer-reviewed journal Circulation that the American Heart Association puts out provided excellent data. On February 14th of this year, they pushed out a collection of articles looking at women's health, but specifically prenatal health. And what they were able to determine was that only 40% of women going into pregnancy have good cardiac health. Over 50% of women came into pregnancy with at least one risk factor for a bad outcome in terms of cardiovascular disease. And even when you correct for socioeconomic status, right? Sally Mae gets her check every week or every month, but my economic status should have afforded me a difference in outcome. But we hear in the media and we have our own personal experiences that socioeconomics, especially among Black women, does not make a difference. And it goes back to the former speaker in terms of those other factors that impact our health, particularly stress, where the American Heart Association has also focused attention on looking at the impact of stress on cardiovascular health. So as we're thinking through from a preconception standpoint, thinking about your mental health, and that we're not just talking DSM, where are we at, the whatever number it is now, depression, anxiety. It's what is your stress level going into pregnancy? And as a pediatrician and as a mother, I think about it even before a young lady or a young person becomes pregnant. What am I doing as a pediatrician to set up those habits to optimize health at whatever point this person decides to become a parent?
Sure, and could I add something?
Absolutely.
So we at the Department of Health and Human Services are always thinking about all of these different causes of maternal morbidity and mortality. And especially when we think about heart disease, it's incredible even when we think about the misconceptions that we talked about earlier today. So many people think that, oh gosh, I had hypertension in pregnancy. They're told if you deliver the baby, it'll go away and you're fine. And so when you see patients afterwards, and I have this all the time in my practice, they think, oh, well, I had the baby, I had hypertension during pregnancy, I'm fine, it went away. The reality is, and most people don't know this, is that a lot of people can develop hypertension after they deliver. And so those postpartum time period is so key and is also what we're committed to. And then furthermore, if you send the patient home right after they deliver and they say, oh, your blood pressure's fine, the baby's delivered, what happens? You get so busy, you're taking care of the baby, you're up all night, you don't know what your blood pressure is. And what are you doing? You're taking the baby to their weight check, their this check, X check. And so a lot of times we don't even know what our own blood pressures are. And so I'd like to share, so through the Department of Health and Human Services, we've worked really closely with the White House to develop this White House maternal health blueprint that has been led by the Vice President Harris. And they have a tremendous support for maternal health through the White House. And through those projects, we are leading a hypertension challenge, which you can find on challenge.gov, which looks at hypertension and challenges people across the nation. How can we improve blood pressure control? And I'd just like to highlight one example from one of the incredible projects where they've given blood pressure monitors to women after they deliver, and they also have the ability to text in their numbers. And so usually we always find that follow-up after delivery is terrible because where's the focus? Baby. What's the weight? Oh, the baby's this, that. What about the mom? And so by texting in their blood pressures, they found that the follow-up postpartum rates where there had been huge disparities between the standard group and the intervention group where they gave the blood pressure monitors, they found that the huge disparities that had existed in follow-up, after this intervention, the African American women had similar rates of follow-up, but more importantly, they had better blood pressure outcomes, and none of them were readmitted for hypertensive crises. And so our goal is to find programs like these and build them up across the country because they're simple interventions that lead to true outcomes. And here we are at this panel where we're saying, how can we find true outcomes? We know the problems, but where are the outcomes where we can find interventions and then make sure that every hospital and all women have access to them?
Absolutely.
I wanted to jump in there for a second as well. I wanted to underscore the importance of preconception health and making sure that we dispel the myth, that maternal health begins with prenatal care. It really begins from childhood, right, and all the way up to adulthood, and making sure that all of our residents, regardless of income, have the opportunity to receive high quality care, respectful care, that they're in control of their reproductive health, they have access to all kinds of contraceptive methods, as well as receive the social support that is needed, especially for our Black and brown moms during the perinatal period, and that access to services such as doulas, such as programs that we support through DC Health, like Healthy Start and Help Me Grow, which provide home visiting services to moms, provide screening services for mental health and referrals to mental health services, referrals to nutrition programming and services in the community. So we want to make sure that we get support from the audience, and this is really a call to action for the audience too. How do we help amplify these programs? The mayor mentioned earlier about we have a lot of programs that exist and are here to support our families. How do we get more families enrolled? How do we make sure that everyone who is eligible to receive support can get that support?
And with regards to support, so maybe perhaps you can answer, and then I'll ask Dr. Richards as well. What type of support is available for folks that are dealing with perinatal mood and anxiety disorders? So I'll start with you, and then perhaps we can talk about DC as well.
So this is around the time where, I know this is not an audience participation moment, but this is around the time where I typically ask people, not asking for your own mental health, but how many people know a friend or family member that has required mental health support for one reason or another over their lifetime? Raise your hand if you know somebody that has had some kind of mental health crisis. And if you look around, you see most hands are up. And that's an important component because I think especially during the peripartum, postpartum period, people are embarrassed. People say there's still a stigma associated with admitting that you need support in the mental health realm. And we want to tell you that that's not something to be embarrassed about. The more you talk about it with your family, with your friends, the more you listen and provide support, even if it's just emotional support to someone that's struggling, the more other people are willing to actually ask for help. Now, let's talk about what help is available. I want to start with Sibley Hospital and Johns Hopkins because that's where I know the most, but there's access across DC, and that's one of the things that even on the previous panel was mentioned. So anyone in crisis, anyone that's having a psychiatric crisis should go immediately to the emergency room. That's where you can be evaluated to say, is this urgent? Do we need to help in real time with, for example, a hospital admission? Or can we give you resources so that you can follow up outside of the hospital? I'll give another example from our hospital where we have maternal fetal medicine specialists who will help people with high-risk pregnancies because of many reasons. We screen every person that comes in for depression, for anxiety, to determine, can we intervene earlier so that we can change outcomes? And so the services that are available might range from therapy. They might include just talking with someone. They might also include medications if that's what's necessary. And so seeing an outpatient psychiatrist, nurse practitioner, or provider is really important to determine what options are recommended for you. And so you can talk about the risks, the pros and cons about doing something like that. Across DC, there are other clinics that are available that have specialists that focus in the postpartum period. Maybe we just need to get you sleeping. Maybe we just need to get you some support at night so that you can sleep, which will change those outcomes as well. And so those are the resources that we try to target. Another, kind of misconception is that, well, they're just going to put me on medicine, so why would I ask for help? That's not always true either. And so we want to lead you to the right answer. If it's not a mental health specialist, you can start with your OBGYN, you can start with pediatrician, your child's pediatrician that might be able to support you, or you can start with just someone you trust, a local member of the clergy or the congregation, if that's where you can start, because we're trying to spread out in different realms. Some people have heard of barbershops now being trained in how to provide mental health support. And so we're trying to actually cast a wide net so that people know how to lead you to the right help based on what your symptoms or what you're experiencing.
I'll just add to that and say that, we all know that providers are trained in their particular specialty, right? And so one thing that we're trying to do is help equip providers with understanding the lived environment of the patients that they serve, help them understand what their implicit biases might be and how to overcome them and have that awareness to make sure that the care that they provide is high quality for all, right? Another thing that we're doing is partnering with our Department of Behavioral Health and other community-based organizations to train providers on the mental health resources and best practices that exist for the perinatal period. And so there's some trainings that are rolling out for providers around that. And so it really takes a village. It takes all of us. It takes also our community-based organizations. We're trying to work more closely with them to understand the needs of our residents and make sure that we can meet those needs down to the basics, right? If you are struggling and need diapers, right? Where do you go? Where do you call? Who do you call, right? And so we have our 1-800-MOM-BABY line, which has care coordinators who will talk to families about what their various needs might be and connect them with service that run the gamut, whether it's needing to access a pediatrician, needing to find access to a mental health provider, needing food, needing a crib. Those care coordinators can help families access those needs, and we're also standing up a distribution center through our Help Me Grow program to provide some of those basic supplies that families might need to get by. And we learned through the pandemic that those basic needs are critical, and we as a health department need to be able to help support those needs as well as all of our amazing community partners.
So when folks are trying to access basic needs or access providers or even just exist in their lived environment, we know that discrimination comes up. We know that poor treatment comes up. We know that these things do affect health outcomes. So is anyone open to sharing a little bit about what their organization or institution is doing to combat this?
I'll start with the American Heart Association. Particularly in their Go Red for Women campaign, we focus a lot of our efforts on partnering with community members and organizations focusing on improving the cardiovascular health of Black women. We know that, as we talked about before, disproportionately, we are dealing with cardiovascular disease before, during, and after pregnancy. And so through information, education, and science-based research data, we're able to provide recommendations for how to navigate through spaces. We partner with faith-based communities and other community-based organizations in order to be in the community. And that's one of the reasons why I accepted the board, or being a member of the board, because I saw what the Heart Association was doing in our community. They aren't just an organization in DC pushing out newsletters every month. They're actively doing the work and providing funding for other organizations to also do the work, not just in terms of creating programs, but also in terms of influencing policy. Because when we think about it, particularly when we're addressing the social determinants of maternal health, the biggest impact is going to come from policy change. And when we're talking about discrimination, racism, classism, sexism, we have to talk about all those components as it relates to maternal health, and the American Association is doing that in a variety of ways.
I would just add to that, it's policy decisions, it's investments like real dollars that you can see that are tagged to things, and then the prioritization within organizations, right? Because we're hit with so many different priorities all the time. I will share it. CVS Health, for just maternal morbidity and women's health generally, there's been huge investments in it over the last number of years. There's $5 million invested in just addressing maternal disparities in maternal health. And some of those things included things like testing models of pregnancy support, like doula support, both for our own employees, and some of the policy challenges we have there is there's not really a board certification, there's not state licensing, so many entities that are very interested in moving that model into care can't do it because the structure of how you credential it and think about, and I know that's part of Vice President Harris's plan, but we have tested a number of models, both sort of virtual and real life sort of reimbursement models outside of kind of insurance plans. A little wonky, but sort of testing what does it mean, like what does it take to bring that into care. And then I'd say just some other investments are, trying to hit on this issue of access and expecting every conversation to go through the eye of the needle of a physician. Physicians also have a zillion things. We have to use all the resources at hand. So we invested in a simple preeclampsia prevention program looking at, we know that for new recommendations, right? The recommendation for preeclampsia is you should assess, see if people have risk factors. It's common, right? 3 to 6% of people, 60% more common in Black women, deadly, right? So you have to assess for risk factors, and then the intervention is low dose aspirin. It's very inexpensive, but we know that it takes about 17 years for a recommendation to actually be fully implemented in practice. That's a lot of morbidity, it's a lot of death. And so how do you jumpstart that message? So we basically worked with the Society of Maternal Fetal Medicine to create basically education checked factor lists for women, combined with an actual bottle of aspirin. And we used our data science, we talked about that in the last session, to identify people who historic data looks like they have risks. You're gonna miss some people, but we can see who has diabetes, hypertension, IVF, advanced maternal age, and just send them aspirin and education. And the call to action is just talk to your doctor about whether this is right for you. And what we found in post-intervention surveys are that 50% of people say that this was the intervention that caused them to have the conversation, and it was about 30% more likely to get that answer from self-reported women who are Black, self-reported Black women. In other words, the value of that kind of personalized information was higher, and it makes sense, right? Because we know that Black women are not heard in this complicated and racist healthcare system. So it's a simple intervention, it's scalable, so we will be doing more things like that. We're actually doing work like that in vaccines because it's a similar story. Only half of women get pregnancy-recommended vaccinations. If your doctor recommends it and they are a vaccinator, it gets completed 70% of the time. If your doctor recommends it, but he or she is not a vaccinator and there's supply chain issues, like they don't stock the vaccine, 50%. And if they neither recommend nor are supplier, 30%. And then everything is 30% worse for Black women. So how do you take knowledge about, we can see in data who is a vaccinator, and it may not be their fault. It may not just be like crappy quality. It could just be they don't have the supply chain capable to do it. Well, we have solutions for that, right? In the district, there are easy access to vaccination. Last year, CVS delivered 60 million COVID vaccines for the country. So we are trying to do the same thing for flu vaccine, which is really critical in pregnant women, and Tdap.
Can I add something here? I am so grateful that you brought up the aspirin, and I feel like if you all leave our panel session today with anything, don't forget about aspirin. And I think that the challenge is when people go to the store and go to buy aspirin, they think it's for someone who's old, who had a heart attack, this and that. My grandma takes that. Why would I take aspirin? And the number of people who do not take interventions that are so simple is horrifying. And especially when you see a patient who's had hypertension, who's had a preterm birth that has had oodles of complications, and then they go through another pregnancy and never took aspirin. It just is something that we need to do better with. And so if you know someone who's had a pregnancy complicated by hypertension, and I imagine that you can think off of the top of your head a number of them, and I can't even tell you, so since I've been at HHS, I have not been seeing as many patients. I'm doing a lot more public health work, and I can share that even in my day-to-day life, people you talk to, friends who are taking care of patients, over and over again, this comes up. And so if you know someone who's had high blood pressure during pregnancy and they're looking to get pregnant again, tell them to talk to their healthcare provider and think about aspirin, because it's such a simple intervention that can have such incredible implications for their health. The other thing that I'll just quickly share is that another project that we have through the White House Maternal Health Blueprint is a project looking at quality improvement projects within hospitals. And so thinking back in terms of how we think about including patient experiences and hearing their voices, through our projects, we're always thinking about that. And so through this collaborative, where we're specifically looking at how we can say what interventions are working at hospitals and how can we make sure that every hospital is using these interventions, we're also working closely with organizations including Mama's Voices, which is an incredible group of many organizations that focus on all aspects of complications during pregnancies. as well as the National Birth Equity Collaborative. And so hearing from those organizations really helps us to inform our interventions and making sure that we're hearing from real people and real voices.
Thank you for that. I wanted to jump in on that point really quickly because we do have the DC Perinatal Quality Collaborative, which has been doing amazing work with our birthing facilities as well as the DC Hospital Association. And one of the first activities that they implemented, while the focus of the project is really quality improvement in clinical care, one of the first activities that they implemented was related to implicit bias training for the providers in our hospitals, right? And so that's another way where we are trying to tackle racism in healthcare, make sure that everyone can receive respectful care and be heard, and also make sure that when we're trying to promote well-woman visits and trying to promote prenatal care visits, that we're also addressing the barriers to that, right? Which is how women are feeling treated when they engage with the healthcare system and how we can partner with our community to address that.
And I think when we talk about issues of discrimination, it goes beyond, right? It goes into the lived environment. It goes into perhaps the safety of the environment in which folks live in. It goes into quality of care, variety of different factors. And so also from a mental health perspective, we know that discrimination is and poor treatment is part of something that folks experience. So Dr. Richards, can you share a little bit about maternal mental health and stigma and discrimination and things that arise around that?
Sure. So one of the things that we try to talk about when we talk about discrimination and stigma is, you know, there's a nuance in now a lot of people receiving care that they want to receive care from someone that looks like them. Now, that could be gender, that could be race, that could be age. There's a lot of different reasons why you seek providers. Well, for psychiatrists, at least Black psychiatrists, we're between 2 and 4% of the total population of psychiatrists. And so what that means is that we're probably not able to provide care for everyone that wants to see someone that looks like me, for example. And so what was mentioned on the panel, teaching our colleagues how to provide culturally sensitive care, teaching our colleagues how to ask certain questions, teaching our colleagues about different life experiences that I might have lived that they haven't, is where we have to meet in the middle. You know, at Sibley, we have a maternal access program where we're trying to do exactly what was mentioned, focus on providing health care to a diverse population, not just people with one type of insurance, not just people, you know, with even private pay insurance, but people who might want to deliver at Sibley because they've heard it, you know, that it's the best place to deliver because they've heard they have culturally sensitive care. Whatever the cases may be, we want to make sure that we're available for them. So in the mental health realm, one of those pieces is reaching out and being willing to share some of your experiences to help get to a fit. I always tell someone when they're starting with therapy, please don't leave therapy after the first session and say, it's never gonna work. It's never gonna work. I've talked with them, we're not on the same page. It has to be collaborative. It has to go back and forth. And so I always encourage people to give 4, 5, 6 visits. I know that sounds like a lot, but to really try to see, is this someone that can meet me where I'm trying to explain my needs and move forward with that? Maybe they won't have the same race, but maybe culturally they'll have some similarities. Maybe they won't have the same culture, but maybe they'll be from the same age group. And oh yeah, we both have little kids at home, or we're both trying to navigate childcare. So they might not check every box, but where they do, that's a bonus. Where they don't, try to meet in the middle with your explanations.
So let's go back to the preconception period, right? Let's go back to talking about folks that are trying to get pregnant. We know that infertility is something that many people face within the district and throughout the country. And so what are some of the resources that are available for birthing people who are facing infertility at the moment, folks that are trying to get pregnant or perhaps have had loss in the past, et cetera? So I'll start with Dr. Armstrong, and then perhaps others can chime in.
Yeah, infertility is an area that really needs a lot of policy and economic solutions brought to it. It's common, about 10% of people report problems getting pregnant. which means they've tried to become pregnant for either, by definition, 12 months if you're less than 35 and 6 months if you're greater than 65. And the causes are very varied. About a third of it is male factor. About a third of it is, sperm not enough, doesn't swim in the right direction, it's not concentrated enough, whatever. And then for female, many different factors, right? Tubal factors, ovulation factors, and then a third of people, there's not an explanation for it. So, the way to think about it is definitely think about prevention opportunities. And one of the key one is actually for female factors, ovulation abnormalities can be related to weight. They can be related to thyroid problems, basic medical problems. So just good primary care can address much of that. Tubal factor, another very important area in women, is largely driven by an STI called chlamydia. There is a recommendation that women women less than 26 get screened every year. The rates for that are really poor. So, just more primary prevention. Problem is when women are being screened, they don't really think about it in infertility context, but it is. And then some of the prevention things for male infertility is semen has this potential to change. Sperm can change over a number of months. So thinking about things that hurt sperm, exogenous testosterone, pot smoking, et cetera, just cut down on that, and that can solve some of it. But then outside of that, in terms of people who have infertility and these primary care things are done and not resolved, the healthcare system is really fractured around this. So for commercial insurance, there is coverage for the evaluation of infertility, right? Hormonal tests, evaluation of tubes, tubal patency, and so on, semen things, and then some lower level of services that are not really greatly effective, Clomid, ovulation induction. Beyond that, for the more technical things like IVF, it's really a challenge. These cycles are very expensive, about $12,000, probably minimally. In some cases, it can be $20,000 a year. And some of it is covered under commercial insurance. It's not covered under Medicaid. For somebody to self-pay for that, good luck. The cost of IVF care in the US is very high compared to benchmark countries. It's about 2 or 3 times more expensive than many European countries. So there's something we could do to really think about the science side of this and how to bring some of the costs down. But in terms of expanding access, it's really a policy issue. So it's not a great solution. It's just a landscape view.
So when folks are starting their conception journey, is there one piece of advice you would give them? So I'll go down each panel member, starting with you.
Sure. Okay. Well, and then is it okay if I also comment on something that we just mentioned? So I'll just say briefly, my background is in internal medicine and pediatrics, and then I did endocrinology. And so, we always love getting referrals from OBGYNs, for anything aspect of under the sun that has to do with hormones. And so I'll just tell you briefly about infertility within my specialty of endocrinology is that over and over again, you get referrals for, thyroid hormones that are a little off. But then when I would talk to patients, I would realize that they had polycystic ovarian syndrome. And that's the most common condition for women of reproductive age. And so I share that with you all because infertility is like one of the hardest things I've seen patients go through. You don't learn about it in school. You don't think about it until you see the silent suffering that goes on because no one wants to talk about it. It's so hard for people who are going through this. And so when you can figure out underlying diagnoses like polycystic ovarian syndrome, which have great treatments for, and you can treat that. And so in many of my cases, I would say, you're being evaluated for infertility, we're checking your thyroid, it's normal, but hey, you have polycystic ovarian syndrome. Here's metformin. It's a generic medication, and then they would get pregnant, and it was amazing. But the problem is we don't always look for these conditions, and they're not always treated. And so that's something, another super important point to take home from today is there is hope. A lot of times when you're not looking for something, you don't find it. And I think some of the most incredible patients that I think back on and how they felt going into infertility and when they had an answer was one of the most rewarding things, both as the provider and then being able to help a patient who's been suffering for years. But I share that because you said, when you're thinking about preconception care and going into it, At HHS, we're committed to healthcare across the lifespan. And so, we've brought it up across the panel today. It doesn't start, when someone is thinking about getting pregnant, which could be at so many different stages and over many different years. But it's establishing those habits that you talked about much earlier on during the teenage years, but then also just being upfront with people and saying, it's really stressful when you think something that should be so easy as getting pregnant is not. And another point that I think is fascinating is how many of you know someone who had really hard time getting pregnant the first time, and it was a terribly, like the lowest part of their life. They talk about it, they get pregnant after years of trying, and then the next pregnancy, they're pregnant in a year and they didn't even plan it because they didn't think that they could get pregnant. And so I share that with you just to say, I think if someone is thinking about the preconception time period, the element of stress that is involved and how that can impact ovulation is something that I don't think we appreciate. And I'm sure, feel free to share from your perspective in mental health too. But I always am amazed in how much the ovaries respond to stress. And so sometimes people don't even think about it. They think, well, I'm trying to get pregnant. I'm not stressed. I'm just trying to get pregnant. But it can be a huge stress. And so when you know someone who's going through that, support them in any way you can. And if they're not getting the right answers, find another person and just keep talking to people until they get an answer. Because yes, there are a lot of cases that we don't know the answer to, but I definitely think there are a lot more that we don't know the answer to because we haven't looked.
Absolutely. I'm a strong believer in the mind-body connection. I struggled with infertility for over a year to the point where I was getting resentful. And I had a patient come in, she was pregnant with her 7th child, and I yelled at her when she yelled at her child because I was just so angry and so stressed and didn't have a space to release that energy. And it's one of the numerous reasons why I actually became a doula in 2020. Was so that from the moment a woman knew she was pregnant, when you pee on a stick, then you call me. I don't start at 37 weeks, I start at like 4 weeks, so that there is protected space to have those conversations. In terms of the advice that I would give, I'd flip the script. The advice that I would give is to the village surrounding the woman who's trying to get pregnant. It's the employer who tells you when you try to push back, I'm about to get emotional, when you try to push back because you're working at 150% FTE, and either struggling with infertility or struggling with pregnancy, and you try to give yourself a little space and grace and ask to have something taken off your plate. And as a Black woman, that's hard to do because you don't want to be the one who can't fully show up. And they tell you to suck it up because everyone's working above and beyond. That's the person who needs to have the advice. It's elected officials who create policy to either support us in pregnancy, and it's the cultural shift that has to happen where women, specifically Black women in this country, are protected before pregnancy, during pregnancy, and after pregnancy.
So I agree with everything that the panel has said. I think they're important concepts that we need to register. If I had to pick one piece of advice, and many have probably heard this analogy before, but I'm going to say it again because I think it's relevant in this space as well, is just to remember, what they say on our friendly airlines in case of emergency. Put your mask on first. And that is the important concept. I'm going to say for mental health, but I'd argue from every panelist here, because we've heard 50% of pregnancies are unplanned. So what does that mean? That means right now, if you haven't been to the doctor in 2 years, go. If you haven't been to the doctor in 5 years, go. Because we never know when curveballs are headed our way. And so what you can do, maybe you're starting this pregnancy journey intentional. Maybe you won't start it intentionally, and it will be, upon you without preparation. But what you can do right now is start to take better care of yourself. And that goes for mental health for sure, but I think I've already kind of beat that in enough. It goes for everything. See your providers. Sometimes to get in with a psychiatrist, it might take 2 or 3 months until you get off of the waiting list. Get on the waiting list now while you're not in crisis. So my advice is start now by taking better care of yourself. And I understand there's sometimes lack of access, and we've talked about the access. I'm not saying it's easy, But if navigating that is hard, it's going to get harder once you're pregnant. It's going to get harder once you have a baby. So start that navigation process now too.
And so we know that when we try to put on our own mask, that sometimes there are curveballs that are thrown our way or that are thrown in the direction of certain folks. And so we know that having access to reproductive health and services is like paramount, right? It's critically important to maternal health. The district is in support of access to abortion care. And so my question I'll just open it to all the panelists, what resources are available for birthing people who may be seeking these types of services? I'll start with DC Health.
So we are committed to making sure that every woman and teen girl is in control of her reproductive health, right? And so based on what we've talked about today, really making sure that everyone, regardless of income, regardless of socioeconomic status, has access to high quality and respectful care. One of our priorities over the next 5 years is to make sure that everyone has access to all types of contraceptive methods, especially the most effective ones, which are long-acting reversible contraception. And when we think about access, we're looking beyond, insurance coverage for these methods. We're talking to providers and facilities. What are some of the barriers they might be experiencing on their end? Are there challenges with ordering and maintaining, stock of certain supplies and medications? And on the patient side, are there barriers like the requirement to have to attend multiple visits in order to have an IUD inserted, those types of things? What can we do to remove some of these barriers and make it easier, even in terms of prescriptions? Are there ways to bundle prescriptions so that you don't have to go back to the doctor every single month? Making it more convenient for women and girls to access what they need to take control of their reproductive health is key.
Absolutely. So I just want to thank all of our panelists today for an amazing discussion. I think that this discussion was incredibly informative and fruitful, and I'm grateful that you all shared your insight, your heart, your professional expertise, and information to our entire audience. So thank you, everyone.